Presenting the clinico-microbiological profile and outcomes in 14 cases of periorbital necrotizing fasciitis, no financial disclosures to make. So necrotizing fasciitis is basically a threatening infection of subcutaneous tissue that mainly affects the limbs or abdominal wall. Occurring of NF at periorbital region is very rare, and the incidence are 0.24 cases per million per annum in a UK study. So here we present 14 patients of PONF and describe their clinico-microbiological profile. It was a retrospective review of 10 years at a tertiary eye care centers, and the diagnosis was established on the basis of clinical presentation of rapid spread of cellulitis associated with subcutaneous necrosis. 14 patients were identified, and mean age of presentation was 17 years with a range of 1 to 64 years, and there was a male predominance. 4 of the cases were having a history of preceding injury, and a preceding infection was seen in 5 cases, which was there as a sinusitis, otitis externa, and erysipelas. So this was a young patient, 2-year-old, with skin infection, that is erysipelas, followed with PONF. This was a patient of periauricular infection associated with PONF, and this was a patient of PONF with insect bite. The clinical presentation, most common symptom was periorbital pain, and the most common presenting sign was tense cyanotic eyelid edema. The area of inflammation involved periocular area only in 9 cases, facial involvement was there in 4 cases, and orbital involvement was there in 1 case. We also correlated the extent of involvement with LRI-NEC, that is a laboratory risk indicator of necrotizing fasciitis score, and the mean score was 1.12, and there was a significant correlation with the extent of involvement, means higher score was calculated with facial and orbital presentation. There was a systemic association seen in 6 of the cases, and immunosuppressing conditions like hematological malignancies, long-standing diabetes, and alcoholic liver disease were there in these cases. All the cases received intravenous antibiotics and underwent surgical debridement, which was in the range of 1 to 4 times. IV immunoglobulin were given in 2 cases, and orbital exentration was done in 1 case. Reconstructive surgery with full thickness skin graft was needed in 12 cases. In the microbiological profile, the most common isolated bacteria was group A Haemolyticus streptococcus. This was a patient with chronic alcoholic liver disease with right-sided PONF with facial involvement. He underwent debridement, and you can see the extent of involvement into the temporal fossa. However, the orbital involvement was not there. There was a state of systemic shock, and he was given intravenous immunoglobulin. And after repeated debridement and skin grafting and reconstructive surgery, he achieved good cosmesis. However, the vision was lost. This was a case of chronic kidney disease with diabetes, and bilateral PONF was there. She also received IV immunoglobulin and underwent full thickness graft. This was a patient of orbital involvement with myelodysplasia. He succumbed to the multi-organ failure. This was a patient following poorly controlled diabetes, following minor trauma, and following insect bite. There were many pediatric cases in our series following sinusitis and insect bite. All underwent surgical debridement. They all underwent skin grafting for the leg ophthalmos, and all were doing well with minimal leg ophthalmos residually. So as per the available literature, PONF is essentially a disease of adults with an average age of presentation being reported as 50 years. And in our series, 8 of the cases were below 5 years of age. We suggest to have a high index of suspicion in children presenting as orbital cellulitis. And we found that mortality rate in our study was 7%, and it was comparable with the available literature and the larger reviews which are published, and support that PONF has a relatively better outcomes and lower mortality than NF elsewhere. So this series highlights that PONF can be well managed with early recognition of disease and prompt surgical debridement of necrotic tissue and aggressive antimicrobial therapy. And to the best of our knowledge, it is the largest series of PONF from the Asia Pacific region till date. These are my references. Thank you very much.
What antibiotic we used?
Ma'am, we use broad spectrum vancomycin with ceftriaxone and metronidazole. In all patients, there were 2 patients in which linezolid was used in place of vancomycin.
Clindamycin actually is suggested for this.
Yes.
Clindamycin, that is the
actually,
best.
We are in a government setup where metrozil is available free of cost. So that's
Metrozil will not work for Necrotizing fasciitis.
Patience is the key factor for treating necrotizing
Yes, but we
fasciitis.
in our series like we had a good results with.
Before you reach the stage of skin grafting, before that also, I think it takes a number of sessions of repeated debridement and taking care. That
we
is
did
very important.
around 3 to 4 times debrided in maximum of cases.
More than that, so that is very important.